Thank you, Dr. Rohit. Very good morning to all. I will be taking you through a quick overview of contact lenses in keratoconus. This kind of a basic understanding is required by every ophthalmologist who deals and treats keratoconus patients. What are the three basic objectives of contact lens fitting? You want to cause minimal physical trauma to the cornea, you want a stable visual acuity, and of course, you want wearing comfort. So what are the optics of using a contact lens? A contact lens produces a precorneal tear lens which eliminates all the corneal irregularities. This provides a new, smooth and regular surface which in turn provides better visual outcome. This is the array of lenses that is available today for treating keratoconus. I will be taking them one after the other. To begin with the most basic soft toric lenses. They have a very limited role and are only used when there is intolerance to rigid gas permeable lenses, of course at the cost of vision. The maximum customizable power that you can have is minus 3.75 diopters, so the remaining can be added on with use of spectacles. The rigid gas permeable or the RGP lenses are usually the first choice in mild to moderate keratoconus, only for the reason that severe keratoconus it's very difficult to get a fit. The various parameters that need to be looked into when you do an RGP fitting are the dynamic and the static fitting, and lastly the vision assessment using over refraction. To start off with, you look at the corneal radius of curvature, that is the equivalent found in millimeters on a topography or a keratometry, followed by you look at the horizontal visible iris diameter. You subtract 2 millimeters for that, and that gives you the diameter, that is the overall diameter of the RGP lens. Pupil size is very important. You need to assess this in bright as well as dim light, because at all points of time the RGP needs to cover the pupil thoroughly. And of course spectacle refraction, which gives you a baseline for the over refraction that you will do after fitting the RGP lens. The two parts, that is the dynamic and the static fitting. The dynamic fitting, you give an adaptation period of about say half an hour, followed which you look at the patient on slit lamp in primary gaze as well as post blinking and the four extreme gazes. So what do you look at? Once the patient blinks, the contact lens will move. You look at the movement. The movement should be smooth. It should be neither too fast nor too slow. The movement should be 1 to 1.5 millimeters. And at the extremes of gaze, when you look for total pupillary coverage. In all four gazes, at all times, the pupil should be thoroughly covered by the lens. Static fit is using fluorescein on the slit lamp. This gives you a relationship between the posterior part of the lens and the anterior part of the cornea. And this is done in primary gaze position. There are three types of fittings that can be possible. The first one is a steep lens to the left. There you will see that this diagram below, this is the place in between the lens and the cornea, where there will be pooling of fluorescein, as you can see in this image in the center, which means this fit is steep. Other pointers towards a steep fit would be when the patient blinks, there will be hardly any movement of the lens. Also, there may be bubbles under the lens while fitting a steep lens. So you know that you need to change to a flatter fit. What is the problem with the steep lens? Obviously it's a tight lens, so it will produce hypoxia, edema, and there is no exchange of tear film, so there will be tear debris under the lens. The one to the right is a flat fit, that is a flat base curve radius, where you will see there is an apical touch. This is the lens and this is the cornea, and there is an apical touch in between. So obviously there is no space for the fluorescein to go, which means there will be a dark patch in the center, as you can see in the figure above. This lens will move too much on blinking. So what is the problem? This lens is directly resting on the apex, so which means there will be scarring. What is there in the center is the optimum fit, which is better known as the 3-point touch or the divided support technique, wherein there is a central mild touch, which is called as a feather touch, which is about 3 to 4 millimeters. In the mid-periphery, there will be bearing of the fluorescein, and at the end there will be a peripheral clearance. Look at the peripheral fitting is also required, where you look at the dye peripherally. This towards the left you see is a very thin and narrow band, which is not ideal. The one on the right is too much of an excessive clearance, What is in between is just the optimum clearance. So as I told you, after the HVID, you subtract 2 millimeters and you get the overall diameter of the lens. You further subtract 2 millimeters and get the optical zone diameter. We are dealing with keratoconus, so you have steeper corneas, usually more than 45 diopters. So these would require a smaller overall diameter just to maintain the centration over the apex of the cone. Usually, majority of patients fit with a 9.48 millimeters. That is, 9.4 is the overall diameter of the lens, and 8 mm is the optical zone diameter. You do have these ready tables which will tell you how to fit the lens. Basically, what you need is the keratometry, and on basis of that K, you can fit it. So this is the normally used 9.48 that I just told you about. When you use on either side, that is, when you make it a flatter fit as the radius of curvature increases, you need it when there's obviously a large pupil to give a total pupillary coverage in athletes and in larger cones or something like a keratoglobus sort of a situation. Steeper fit would be needed for the most steeper corneas. Rule of the thumb would be to flatten the base curve radius by 0.25 diopters for every increase in the overall diameter of 0.5 mm. Similarly, to steepen the base curve radius by 0.25 diopters for every decrease in overall diameter of 0.5 mm. The power would be, after getting an ideal fit, you over refract with the spectacles, and that is the final power that is incorporated into the RGP, and it is customized for each patient. The vertex distance needs to be taken account for all calculations above plus or minus 4 diopters. So what if the patient cannot tolerate an RGP? What do? There are options with combined lenses like the piggyback or the hybrid. What's a piggyback lens? As you can see, this is the edge of a soft contact lenses which is fitted first, and on top of that an RGB which bears the major part of the power is fitted on the soft contact lenses. So obvious advantages. The rigid lens gives you good vision, and the soft lens will give you superior comfort. But obviously it comes with some problems because you're using two lenses. So it is a thick lens, it produces hypoxia, neovascularization, it is difficult to handle. With the new availability of the super decay silicone hydrogels, these problems have to some extent come down. This is the fitting of a piggyback lens. I'll not go through it, but what is important is you use high molecular weight fluorescein, which does not stain the soft contact lens. Next option would be hybrid lens if you're not comfortable with the piggyback. The central part which bears the power is the RGP, and there's a soft lens peripheral skirt which gives the comfort. So this is called as a hybrid lens. Problems could be tearing at the junction of the RGP and the soft lens, and also there are some difficulties in the insertion and removal of these lenses. What are these fully keratoconic designed special lenses? The Rose K family and the scleral and the mini scleral families. The Rose K family is a unique lens which was devised by Dr. Paul Rose. He has these complex computer generated lot of data from the peripheral curves, and he's devised these Rose K lenses, and they have a very high success rate of fitting in keratoconus. Initially the Rose K lenses had multiple back curves, okay? So this produced some amount of spherical aberration because the light was not getting focused at one point. So the latest Rose K2 have been developed which have an aspheric back surface which take care of the spherical aberrations. This is the entire family of the Rose K lenses. PROS is prosthetic replacement of the ocular surface ecosystem. In short, it forms a liquid bandaged contact lenses over the entire cornea which gives constant lubrication and oxygen supply. These are the mini scleral lenses, the same version with a smaller diameter, especially for keratoconus. And the optics are similar where they vault over the cornea and the rest of the sclera. So they give better comfort, less mechanical trauma, and better vision. So finally, contact lenses may be challenging, complex, may involve a lot of cost and time on part of both the patient and the doctor, but it is rewarding at the end because majority of patients, it can help restore good vision in keratoconus. Thank you.